1.2 mm, there was a perforation. And also there is some calcification which was there in the root of an 11-year-old boy. Can you imagine an 11-year-old boy having some kind of calcification? Very rarely you see those things. But now you see, because we are seeing a lot of calcifications we are also seeing in the young individuals, right? So we went ahead, this was the clinical scenario. Again, thanks to the world of magnification and the tools what we had been using it. We cleaned that area up, used ultrasonic tips, and this is what exactly the stone which was lying into that root canal. So you don't only see a pulp stone, you also see a radicular stones. Time is changing from the pulp stone, so be vigilant. Sometimes you are not able, sometimes you're able to get a canal, but you miss a stone in the canal. Time is changing. Even I think anatomies are also changing. They are becoming different. I don't know why, but it is changing. Do you think it is really changing? No. The vision to see is changing. Okay, that's what we did. We opened it up, and this is what exactly the apex of that premolar what you can look at. Now this apex looks beautiful, but it's as scary as ever. Because when I looked into that, and we went ahead, because it was a large, big open apex. So what I did, I took the gelatin sponge, what you see there, go and pack it right up to that area. Pack it, and then place the putty. This was the initial situation, right? It looks like a single canal. Is it a single canal? The answer is no. So everything changes once you see well. So start spending time on your diagnosis, something which is very important. A right tool at a right place will give you the results, right? That's what we did. We opened it up again, and then we packed it with the putties, bioceramic materials. That's always my choice. I had been playing with this material from 7 long years. Every day it's been playing, right? So we fill it up. Now we place the putty and we place the sealer. Finish. Resin modified and the glass ionoma. Let me show you. And the final results. Something which is doable, achievable, and definitely predictable. Today's endodontic and restorative practices are becoming predictable. You can tell the patient, yes, it is predictable. Gone those days, again, thanks to the tools and the skill. It's very important because you have to drive the car. Automatically, magnification will not go and help you. You have to learn it well, right? So this was 2-dimensional. I always go with CBCT to see what is the sealing I got in my root canal procedure. And it's an absolute void-free sealing, what you can see, right? And this is how exactly you do. Now this case, such cases you get in your clinical scenario, right? Very simple, right? Very simple. Let's see the CBCT. Now what you will going to do? See, you have a resorption, internal resorption which is there, and also the external resorption. So again, understand the value of a diagnostic tool, that when you are in doubt, use that tool. Okay, this is something very important. Let's see clinically. This was the situation and this was the clinical situation. It's an internal resorption, right? You have to take care of that resorption very well. How you are going to take care of that? You have to open it up, right? And that's what we did. And such a resorption, when we went for a CBCT, they didn't wrote one thing, that it is a communicator. So again, clinician has to be very vigilant. So what we did, we used ultrasonic tips and then we troughed that area so that I can get the access to it. So when I troughed it, this was the resorptive area which was there. Again, a communicating, right? Thanks to world of magnification. Now what you see here is almost 21 times larger because of the tool. Otherwise, you cannot see this because the tooth is so small. Okay, that's what we did. We removed it up and then we took and placed our precise placement of our material right at the site. That's the beauty. And beauty lies in the hands of her, not hands. Earlier it was in eyes, not in your hands. Right? So beauty lies in the eyes but also in your hands of the beholder. And the time is changing. So you need to change those things with you. Right? So we go ahead, place those materials step by step, and then we condense it. How many of you have used gutta percha in your clinical practices? Anybody using gutta percha? Everybody. How many you have thrown? जो ऐसे टेढ़ा बेढ़ा था उसका क्या किया था? कहाँ फेंके? Now start realizing those gutta perchas which you threw away, which was slightly bent, can be your pluggers at this point of time. Have you ever thought? Innovation begins from your dental chair. Right? So those gutta perchas which you have, which you see they are all distorted or which are like you take out from the box and the tip is bent, just cut the tip of that GP 4 millimeter and it becomes your plugger. And you can plug those materials right there. So now think how much GPs you have thrown. I don't know. You know the calculation, because in dentistry everything is cost. Right? It's not about the box, it's about the quantity. Okay, we did that, then we adapted that material well, step by step, compacted it, sealed it, and that is how exactly. So the choice lies with you. You can do with or without gutta percha, right? So we went ahead, sealed those canals, and that is where exactly we reach. From here to here and to here.